All right, everyone, my clock shows 3 after, and so I think we're going to go ahead and get started. First and foremost, I see a lot of team members on, and I also see a lot of really familiar partners to me. So thank you first and foremost for taking your evening to be with us. I raced home because I've got kids going in separate directions this evening. So I'm coming to you from a basement working space, but Janae and I are going to tag team a presentation tonight. But first, let me talk to you a little bit about what we're doing here. And that will become, I think, even more clear as we get a little bit deeper into the presentation. So over the course of the last couple of years, we've taken a lot of feedback. As like I said, I'm going to get into this in a little bit more detail here in a second once we get into the slides. But it's really occurred to me, and we've tried this out in a number of other sections of our agency, that it is very healthy to have a regular, predictable space where you can hear from us about the major initiatives and program design changes that we are working on in the agency. And we're going to start to orient you to that, specifically to our Child Protective Services work. But there are other aspects of our agency work, like Medicaid waiver redesign, that we think a lot of partners in this space would like to hear about. And so I worked with Janae and her amazing team to think about how to design a regular colleague town hall, which is exactly what you've joined tonight. This will be every other month, dedicated space. We'll go through some high level setting of where we are, what we're thinking about. But we're going to leave plenty of time for questions. I mean, we've got actually a manageable group here. We've asked a number of our senior team members to be on the call so they can hear your questions, your concerns, your feedback, and we can work together as a team because we are all committed to the same objective here of keeping children safe first and foremost, but really making sure beyond that that we're helping families thrive. And that's really the core of our focus and what you're going to hear about tonight. Janae and I are going to tag team this presentation. So we're going to hear from you, or you're going to hear from us rather, for several minutes. We're going to try to go through it quickly, hopefully not too quickly, so that it lands and resonates. And then, like I said, we'll leave plenty of time for questions. For questions, I think it's a manageable enough group where we can really, like, you can raise your hand or just really like turn your camera on, come off mute. And everything is fair game, whether we've covered it in this topic area presentation or not, right? If there's something that you're seeing that is a problem in the system, something we need to be paying attention to, or dare I say, you have something to make sure that we know of that has gone really well. Lots of times, Janae and I are getting a lot of exceptions, like things that aren't going well, but it's really helpful when we also hear what's working well so we can give that feedback to our team. All right, so Claire, I think we can move on to this next level setting slide. So tonight, we are going to go through just a really clear level set of our family well-being division, what our new agency structure looks like. We're going to talk about the listening sessions in a little bit more detail, kind of how we got there, which leads into top priorities. Our Child Protective Services assessment, which was led by Change and Innovation Agency, an external review of our practice model here in Iowa and kind of where we're headed. Then we're going to go through some service and practice changes, and Janae's going to lead us through that. And then we're going to wrap up with constituent feedback, process changes, and how we're really not only escalating case-specific questions and concerns, but also how we're learning from that to really look more globally across the entirety of the system. All right, with the next one, I'm going to introduce Janae, who needs no introduction.
That's the extent of my introduction. Okay. My name is Janae Harvey, and I am the Division Director over Family Wellbeing and Protection. The slide up in front of you shows our leadership structure within that division. Ryan Page is our Director of Childcare. Shifting over to the far right, Shelley Horak is our inaugural Director over Early Intervention and Support. And Lori Frick is our Director of Child Protective Services. Lori, would you like to come off mute and do a quick introduction?
Sure, yeah, thank you. Lori Frick, a CPS director. For those of you who are not with HHS, all of the service area managers report to me. The operations director and the policy bureau chief all report to me under this unit of the Child Protective Services. So thanks. Good to see you guys.
I want to underscore for everybody on the town hall, those of you who have not had an opportunity to meet Director Frick, she was previously the service area manager in the Eastern service area for many, many years. And before that, she also served within our provider community. She was an employee of Families First for a number of years, so she knows the work from that angle as well. And she is also an inaugural director in that she is our very first director in the state overseeing both the policy and the practice of child protective services. And it's a huge job, and she brings extraordinary talent and passion into this role.
I think so much so that she told us she's been wanting to do that since 12. Is that right, Lori? Yeah.
Yep, junior high, yep.
All right, so the culmination of this work and really thinking about how to perfect the organizational changes, right? We can align organizational changes, and believe me, that matters. I mean, the idea that the state was operating policy and practice separate was an immediate observation from my perspective when I landed here 4.5 years ago. So this is a long time coming to get the right organizational oversight in place and direction. That matters. It matters significantly. But honestly, if we don't know those deeper challenges that our team is facing, that our partners are facing, the rearranging of the deck chairs does nothing, right? It has to happen in a complementary way. So a couple of years ago, I embarked on a listening session. I did that work with the Chief Justice. We had a number of really significant findings, and I'm just going to refresh our memories around that work. We heard not enough attorneys in the system. I know there's been some progress made, but it's still a challenge. We heard her talk, Chief Justice Christensen, talk a significant amount about not doing perm terms at the same time, her coined phrase. I think in some areas that's also still a challenge. We heard a lot of feedback about lack of service array, and that really spurred us to think about behavioral health redesign and waiver redesign. We were already on that progress, working in that area as an agency, but it really gave us that solid gut reaction that there are significant areas of the state with immense challenges and that it's disproportionately affecting child welfare. We also heard about our own workforce, right? Frustrations around turnover, frustrations around untimely court filings, documentation in court, as well as not seeing kids. And we're going to get to that a little bit later. And all of that was kind of a symptom of having this really pervasive turnover rate. We also did a lot of internal listening, right? Because I fundamentally believe, like, if we don't have a really strong team, we don't have anything, right? We can talk about all of the challenges in a system, but we've got to focus some level of significant effort on focusing on our own team so that they are strong to do this really tremendously hard work. And so there's been a significant amount of effort placed on that early on in their inaugural tenure in their new roles. But Janae and Lori have done a lot of work there. And what you see on this slide is really the feedback from our team. I'm really pleased to report that we were talking about this today in a different capacity, we've made a lot of progress in this area. So a year ago, we were nearly spinning out of control in terms of turnover. We're not all the way like, yes, this is Kelly saying we've arrived, right? And I mean, we are not without challenges still in turnover, but we are sitting in a very different place after a number of these different initiatives have been deployed internally and much more stable than we have been. So now our role is to focus on different things, right? We have newer, greener staff. We have a lot of newer supervisors. And so how do we really support that new leadership to be strong in their new capacity, ensure that they're trained well, and kind of double check some of the spaces where we're seeing additional support needed in decision-making and in court interactions. Next slide. All right, Janae, I think you're up again.
So Lori Frick and I have been in our role a little over a year. And as we entered our new roles, we sat down and talked through what priorities and what urgency and what's kind of our laser focus as we enter these new roles. We knew that we could not take on all the things at once. And so we really need to narrowly define what are the specific issues that we really wanted to hone in on. The slide in front of you represents those top priorities that Director Frick and I shared. We knew we needed to, number one, stabilize our workforce And the way we needed to do that was a deployment of creative recruitment and retention efforts. So we had to start there. In addition to recruiting and retaining staff, we heard a lot about our team members not feeling like we were a very trauma responsive organization. Lori in particular really started to lean into that problem and has spearheaded some efforts with the Department of Public Safety in deploying something called a CISM team. A CISM team is our crisis incident stress management response. And so today, when a team member goes to a particularly horrific or traumatizing family situation, they are now well aware that they can ask their supervisor for this additional support. It is deployed statewide, and it is therapeutic in nature. And when our team members are lucky, it even includes a support dog by the name of Mr. Pickles. Mr. Pickles goes around the state sometimes. As Director Garcia has already indicated, our workforce is in a much better place than we were a year ago. We continue to look at opportunities to invest in our team, including establishing a statewide mentoring program. We have launched a relationship with the university at UNI in order to support an MSW degree program for a select number of staff. So those 5 team members will be starting in the fall, and we're not done. We're continuing to figure out what do our team members need in order to have balance, feel supported by their supervisors, and feel equipped to be proficient at the work in front of them. The second priority we decided to take on was reducing our long-term shelter stayers. And looking at the data, it was really clear. We basically had 2 pools of youth. Youth who either moved out of shelter quickly, and those who reached the 30-day benchmark ended up staying months and months and months. So we have rolled out a new protocol that includes our RTS, so our 4 Oaks partners, coming into those shelters to meet with the youth, getting to know them more than what they are on paper in order to do better matching with the foster parents. And we also have enhanced requirement for our HHS team members to go out and visit those youth more frequently when they've reached different longevity benchmarks. Today, the data shows that we have seen a significant contraction in the number of youth who are in shelter more than 30 days. The constituent complaints is obviously a priority, and Director Garcia will talk a bit more about that later in the presentation. But I just wanted to underscore that our commitment to hearing about concerns and being responsive to those concerns, either to provide additional information around what is going on in a particular situation, or using that feedback to learn more about training opportunities, altering policies. Some of the feedback we've heard about has included buying new and different services. So we are really committed to staying in dialogue with everybody who is in our stakeholder community. The 4th issue we're working on is coming up with flexible spending so that in real time, our HHS team members have the money that they need available in order to support the needs of families. This has looked like a supervisor reaching out to us to say, hey, I was just involved in removing 7 kids this evening. They're all hungry, and HHS workers are pooling their money in order to feed these kids. Director Garcia and I received that email and immediately said, we can do better than this. So we are actively working on a protocol and a strategy that will get real-time flexible funding out to the service areas so they can be used with the appropriate oversight, but also the discretion that meets the real-time immediate needs of the families and the children that we serve. So still very much building out and working on that priority. And the last is the listening tours and feedback. So we have followed Director Garcia's leadership. She immediately did statewide tours in conjunction with Chief Justice Christensen. Director Frick and I emulated that effort last year by going around the state and doing deep listening sessions with different levels of HHS team members. We met with SAMs and SWAs and supervisors, CPWs, and SWCMs. We listened to them, we collected those themes, and we've been using those themes in order to set our own priorities over the last 12 months. We are committing to continue doing those listening sessions, and we'll have one planned for later this year.
Thanks, Janae. I think next we're going to talk about our assessment. So this was something that was really important to me. Launched the assessment as we were thinking about the organizational changes, thinking about the challenges we had in turnover, right? So the obvious play there is we need more staff. And listen, there may be areas where we need more staff, but we are operating off of a legacy IT system that is as old as I am. It's mainframe, it's green screen, you can't use a mouse. It has no mobile technology function. And it, as you well know, as partners, doesn't have portals over to the other areas that make up a child protective services team, right? And our work, the way that Iowa hands off cases, having worked in the Department of Family and Protective Services in another state, is very different than some of the models that exist in other states. And so I really wanted an outside look at the way we're doing our work, the handoffs, the spaces where we might be doubling up and be really inefficient, and then some spaces where we're like missing things, and we needed to fill in those gaps. And so in doing that assessment, to make sure we got the right group of people to help us with this, I asked this question. I added this question to the RFP: are children and families better off because we are involved? Far too often in the system today, in fact, Janae and I were working on a couple of cases earlier today, the answer is tragically no. And we need that to be the case, right? Our capacity needs to be so that we are there to help. And when we leave, families are better off because we were there. So next slide, we will see, this is the way they did their work. It was important to me. Again, it's an outside vendor, really smart people who have done this work at different levels in other states, right? It's not just a fancy consulting firm. They're actually people who have done this work. They brought to the table also a really significant force of data, and some really smart people who helped us kind of plug away at the data. They did a lot of on-the-ground interviews too, and that was really important. So, so this slide is just articulating that. Next slide. So this is the theme. The first two are really important and they thematically go together. So we have got to get really precise in the way we're thinking about the role that child welfare should play, right? You know, classic example here is to think about those repeat calls from teachers and school administrators who see a problem with a family, but when we go out and we make that assessment, that level of abuse or neglect doesn't rise to a statutory threshold. Typically and historically, most often we just leave. We close the case and we leave. And then we see those families come back in. And I get constant calls from, again, you know, typically it's a school administrator, like frustrated. Why are y'all not doing something with this family? Where our statutory threshold is high, and that's not necessarily a problem. For the government to intervene on your parental rights, it should be a high threshold. But that doesn't mean there's not a challenge there. So, right, so recalibrating our work to really increase those prevention efforts and to offer different avenues, assessments, and reserving the right for investigations in the spaces where we need investigations, right? And recalibrating this work to include early intervention and supports. And that is the work of Janae's division, right? So it's not just Child Protective Services that holds a very incredibly important place, but it is more than that. And we intend to harness the energy of all of our home visiting programs, Early Childhood Iowa, and some new additional supports out of advocacy offices that came from the Department of Human Rights to do that work. Also, obviously, and we're going to show you a slide here in a bit. We're really doing phenomenal work in this state on making sure that children, where possible, are with their families and natural supports. And we've got to do a better job of supporting those kinship placements. And for children who can't safely be with those caregiver natural support networks, we need to do a better job of really bolstering our relationship and supporting foster parents. So in the opposite month that when we're meeting with y'all, we're going to be meeting with that group of supports, right? Making sure we're hearing directly from foster parents and kinship caregivers on a regular basis to understand what they need to be successful. I meet with groups on a regular basis, and I want to broaden that network. Also making sure that, again, when we're in a house and we're seeing, okay, what do these barriers look like, that we're really arming our workers with the force of the entirety of HHS to meet those needs. You've already heard that we're committed to doing better by supporting our staff, making sure they are well trained, they feel supported in and out of work. The trauma is real, and we're doing more work around bolstering that support. And then really, again, making sure we are taking true advantage of those efficiencies. I'm never afraid to go ask for resources. I've done that every session and had a really, really successful track record in the legislature meeting those needs. And of course, the governor has been tremendously supportive in identifying and supporting those internal needs as well. But first, we've got to get real efficient in our system and make sure we're making use of technology and the right handoffs in our workforce. Next slide. So these are the recommendation, as it says, standouts, right? Key recommendations. You probably heard a lot about the supervisor to worker ratio, and I realized, Janae, I just took your slide. Apologies. I will pause.
It's okay.
And so that got picked up by the House. That's still being debated, and so we will see where that lands. Like I said, our take on it was that we wanted to do some work internally around it. Although we recognize that we have been off kilter in that ratio, it shows up in the assessment. Janae, I'll let you pick up since I stole your slide.
Okay. A second recommendation, the ability for us to reorganize our work so that we provide services earlier in a case. Right now, we typically wait until the end of a child abuse assessment in order to determine if a family is eligible for ongoing services. That's how it's been set up in Iowa for a very, very long time. We need to figure out how to re-engineer that. So from the moment a CPW is in the home, if they go, wow, I'm here doing an assessment or an investigation in terms of abuse or neglect, but this family has needs, they aren't left waiting for those needs to be met. They shouldn't have to wait for 30 days for us to hand off that family into services. So we're gonna have to be very thoughtful about this. This will take longer term conversations also with our family-centered service providers and other community providers, but we need to start getting those families handed off, especially when those families are in crisis. That's when they are much more likely to engage in services. A warm line is a fascinating concept that is already deployed in some other states. And the idea of a warm line is that it serves as an alternative to a child abuse hotline. A warm line needs to connect to a formally developed information and referral community pathway. Otherwise, people will continue to report abuse and neglect when frequently what they're seeing with families is need. They are seeing a family that is maybe unstable, and maybe that shows up around a family having some food insecurity, or maybe missing medical appointments, not having reliable transportation, issues like that. In the absence of an alternative to a hotline, people, when they're worried, will continue to call a hotline. And we want to really figure out how to build out our system so we are a service-oriented system, and that the CPS team is there to do the deeper intervention in those more severe cases. So again, this is work that will fit squarely in the early intervention and support team. So we will have some exciting updates deploying out of that team in the near future. Another idea that emerged out of the CIA assessment is the possibility of social work case managers who may be working with kids who there's been a TPR, but we've already identified who the adoptive parent is expected to be. And CIA picked up that for some of those social work case managers, there may be closure, positive closure, an exclamation point on the work that they get to do if they're able to see some of those kids moving from a goal of adoption all the way through that goal actually being achieved. So we will be taking a look at what might be possible or what might be some challenges there, but we're definitely going to take a look at how that might happen. Something else that was identified by CIA in their assessment, and they did do some comparison of Iowa compared to a number of other states, and it stood out to them that the good cause language in the China adjudication stood out to them as being very open and not well defined. CIA was very clear that the needs are real. The families who are coming through that good cause language, they have needs. They have kids who have behavioral health needs, mental health needs, substance treatment needs. They need things, right? But they're also acknowledging that foster care, a removal from a family, it is not the remedy to find those services that a family may need. So unfortunately, as many of us have seen, in the interest of getting children better served, sometimes what we have seen is kids who kind of get lost in the foster care system. Their trauma becomes exponential. They become increasingly destabilized, and they are left wondering why their family gave up on them. Again, I want to be very clear, CIA did not make a recommendation to turn off a China pathway. They really pressed us in the report to clarify, are the families seeking services? Do they have help seeking those services? Just making the threshold really about being a service-oriented system, which really aligns with all the other work that Director Garcia just described. The second to last recommendation is that we should have a separate licensing process for relatives and fictive kin that is expedited. And that recommendation from CIA came just in advance of, at the federal level, them reworking their rulemaking around the standards for getting relatives and fictive kin licensed. So really, CIA was slightly ahead of their time. They could read the tea leaves, and they made that formal recommendation in the report. We have a work group that is getting started this month to do a crosswalk with our current standards for what we make relatives and fictive kin do versus what federally is required and our own code requires. And basically, we're going to be building out the sufficient oversight, but the quickest pathway. If it is not a safety concern, and especially if kids are already placed with those relatives and fictive kin, we really want to press on getting them a license so they can get the full training, oversight, support, and financial assistance as our foster parents. So we are taking up that cause immediately. The last recommendation from CIA is about us developing a standardized model of practice for our supervisors. Our supervisors are critical. They are the linchpin on making sure that the good work is happening with our team. We obviously have a number of veterans who are doing the CPW or the SWCM work. They've been with us for decades, but we also have a very high percentage of staff who are new. They need additional meeting time with their supervisor. They may need their supervisor to do ride-alongs, help them go to court. And we want to be sure that that consistency among supervisors is the standards are very clear and that it is happening statewide. So we will be doing some work in that area as well. Over the next couple of slides, I'm going to quickly talk about the service array that we have in place to serve families. Family preservation services, we're going to start there because it's our most intensive level of service. And it is designed to both be short-term, it is home-based, and the whole goal is to keep those kids safe and stabilize that family. That is a family in crisis. And that is a family that in the absence of family preservation, those kids are likely going into foster care. So we deploy this service in 10-day calendar units. Families are eligible for up to 3 in a row. And when we deploy family preservation services, we also hold a child safety conference. And that child safety conference pulls the whole team together to say, what does this family need? Let's do some out-of-the-box thinking. Let's get those services and supports in place, and let's keep on re-upping that until we get through this crisis and can get things settled down. Next slide. Safe Care is our evidence-based intensive parenting program. It is a curriculum-based that is modular. It is delivered in the home, and it targets risk factors associated with child abuse and neglect. Some of the evidence behind Safe Care includes a 5-year longitudinal study out of Oklahoma that demonstrated that families who graduated from Safe Care had over a 70% reduction in returning to the attention of the child welfare team out in Oklahoma. This intervention is for families with children under the age of 6. So if a parent has a child 0 to 5 and they're involved with a CPS case, we should always be front of mind thinking, is this a Safe Care family? The 3 areas of focus from Safe Care includes parent, child, and infant interactions, ensuring that the home environment is safe, and making the appropriate health decisions for those children. So covering attachment and bonding, home safety, and health care decision-making. This service can be graduated from in 18 weeks, but that's uncommon. It usually takes families about 6 months. It is a service that happens at least weekly. And when families graduate from this intervention, we know that those kids are going to be more safe and better off. Next slide. This is one of our newest services in the state, our Kinship Navigator program, and especially as we continue to increase the number of kids who are placed with relatives and fictive kin, combined with our efforts to get them an expedited license, we expect to see even more families benefiting from this program. It is a support for relatives and fictive kin. The goal is to give that caregiver the immediate emotional, social, and tangible support they need to care for those kids who are suddenly placed in their home. The goal is ultimately to stabilize that child and make sure that they're not then experiencing lateral moves. Success looks like connecting that caregiver to community resources, concrete supports, and also letting them know who they can call when they're having a bad day. We don't want them feeling alone in this process. It can be a dizzying process, and we want them to always know who their phone a friend is. Okay, some of you are probably aware of this, but for some of you, this may be brand new. We, as the department, recently made the decision to make a pivot from solution-based casework and over into motivational interviewing. There are a couple of really prominent reasons we are making this pivot. The first is when Iowa selected solution-based casework as our evidence-informed model to implement, we were an early adopter of Family First. And at the time, the federal clearinghouse for what models would be eligible for 4E drawdown was not established. So we worked closely with Annie E. Casey to select a model that fit Iowa's needs and was in the California Evidence-Based Clearinghouse. Over time, that federal clearinghouse has continued to evaluate different programs to determine which ones are eligible for the maximum federal drawdown. Solution-based casework did not make the cut. So we have unfortunately learned that SBC is not eligible for 4E funding under the Family First Act, but much to our surprise, motivational interviewing was approved. We are familiar with motivational interviewing. It is already a required component of the family preservation services that I already discussed. So we have familiarity with MI. It's eligible for the 4E drawdown. Our family-centered service providers are familiar with it, and it is syncing up very nicely with some broader HHS efforts around what we're calling our HOPE initiative. So we'll talk more about HOPE at another town hall, but HOPE and motivational interviewing sync up very nicely. And last, I would be reticent not to mention that Christy Oliver has shown tremendous leadership in this space, helping work through the challenges of shifting from SBC over to motivational interviewing. She's held countless meetings with the family-centered service providers, and we are really, really grateful for our provider community who is willing to pivot and evolve and change with us as we learn more. We sometimes have to make these big system changes, and it is not easy, and we are really grateful. The timeline for getting these changes made will take place over the next approximately 9 months. We anticipate having an established motivational interviewing training set up statewide, along with a fidelity system, quality assurance, and oversight set up. And should by between January and March of next year, we should be able to be pulling down federal 4E dollars to help further fund our CPS system. So a lot of work, a lot of change. We will be sending out additional information to judges and our legal community so you can be more familiar with the key components of motivational interviewing. Here is a little keyhole view of what motivational interviewing is. And I am suspicious that many of you will pick up on kind of small changes from SBC over to motivational interviewing, because there's a lot of similarities. Motivational interviewing is a technique that guides behavior change. So it's really implemented with the expectation that you're building a trusting relationship and you are using the individual's own goals in order to set the plan moving forward. Now, I want to be very clear, in child welfare, those parents are not involved because they said, that's my goal. I understand that. But when we can use kind of natural motivation, maybe the motivation is that the parent wants to have a safe, loving relationship with their child. And so what we need to work on is some substance use disorder. We need to work on some substance treatment because you're not going to be that loving, consistent, caring parent if you are substance addicted. So we would make connections within the framework of how we do our CPS work. But the idea is heavily engaging the family, motivating them, using goals that are specific, measurable, actionable, reasonable, and time limited whenever we are working with our families. And you will see those goals showing up in a case plan. So we are all working from the same expectations, and the family is really clear what is expected of them from the court perspective and from the HHS perspective. Next slide.
Janae talked for so long, I forgot my unmute button. Really nice, Janae. So this is the slide I referenced earlier where you can see we are doing a really excellent job placing youth with relative and fictive kin. And in the next slide, I believe we show the downward trend of use of group care. A couple of things there. One, this slide shows all youth. And remember, we buy capacity for our colleagues over in the juvenile justice system at JCS. And so our capacity is actually much smaller than 324. In fact, today we did take 12 beds or stated the intention to take 12 beds offline. We are intending to sever our contractual relationship with LSI for their Brentwood QRTP campus. We have worked on transitioning youth off of that campus and will continue to do so. We've given ourselves up to 30 days to make that transition, but for a temporary amount of time, those 12 beds will be offline, and we're working with our phenomenal set of QRTP providers to think about alternative pathways of creating additional capacity within that existing provider network. So more to come there, but didn't want you to be surprised. We've sent out an email too, but while I've got you kind of in person, I don't want it to be a surprise that that has happened. All right, next slide. This was an area of really high interest for me. Caveat that when I asked for this question very early on in my tenure, it was largely a hand-counted exercise. Again, I'm going to harken back to our really outdated IT system. What I want to show you here is visits by quarter. It's not just HHS. This includes JCS and our Meskwaki colleagues as well. And so it's not representative of just our work, but I think it's really important here because our work was contributing to some lower scores. You know, it is, from my perspective, mandatory that we see all youth in our care every month, period, full stop. And our goal would be to get this percentage, which we are now within range, kudos team, to 95 or above %, and that we measure our own work to be, you know, as darn near close to as 100 as possible. Again, there are reasons why an individual worker might not be able to make it, but we are a system. And so we shift those resources to ensure that all youth are seen and not seen in the moments before court, right? That does not count as a visit. And Janae and I were talking earlier this afternoon, you know, the deeper work here is around relationship building. And if you're not seeing kids, not only can we can't verify whether they're safe or not in whatever placement they're in, but B, you can't build a relationship if you're not physically meeting, right? And so really working on that has been key. And so that is both a practice move, but it's also a culture move. And I'm really proud of the commitment that our team has shown around driving this number. I'm sad to say that we had to even have the conversation, but we did, and it was met with open arms by the team. And we're sitting in a very different place. And we'll continue to show you that progress. Next slide. Yep. Okay, so last one, I think, before we hit questions or comments, feedback. So I get a lot of calls on individual cases. I get them from all sorts of people, right? Therapists, administrators, parents, concerned parties, grandparents, foster parents, right? And the like. And so we've established a very clear process now. Instead of these one-offs that come into my inbox, we have established a process for clear constituent feedback. It's really important that our folks have a place to land, right? And by folks, I mean like the all-inclusive parties that are concerned about the outcome of case, concerned about somebody involved in our system, whether that's a parent, a foster parent, et cetera. And so now we really do have this very clear feedback loop. It doesn't just go into an amorphous black hole. It's not just staffed by me, right? And that we are really thinking about escalating those urgent member needs through a dedicated workforce team. A lot of those cases tend to be more complex, not all of them, but a lot of them do. And so our social worker 6 folks are dedicated to making sure that they are managing those cases. And you can see there that we do the ones that come to me. I'm going to put that work closest to the team, but I'm going to stay on top of it. And the team regularly updates me on what is occurring with those cases. It doesn't mean that I don't take meetings with individuals. I frequently do. What I will tell you though, is since we've implemented this constituent feedback loop, the number of cases that I'm getting coming straight to me are lower, which means that it's working. I really very much believe in transparent feedback. I want to hear it. I can't fix things I don't know about. But I also want to make sure that it's not just one-off changes, right, or interventions, but instead really working to identify problems in a system, because those direct calls are sometimes a signal that a process is off, right, or something's getting stuck. And so we've really been able to learn now that we have this process in place. All right. Okay. So that was our presentation for this evening. Again, we are going to be bringing different topics every other month. Really making sure that it's kind of a forum to learn and level set on what we're working on. But now comes the more interesting part, perhaps, of the evening. And we've got just a little bit of time left, although I am certainly able to stay if the dialogue takes us there. Who has a question, comment, or otherwise feedback?
While people are deciding whether or not to comment or provide some feedback, I'll just add to kind of what the director was saying there at the end around constituent complaints. I guess for those of you who are not HHS, by all means, please allow, if you are hearing something, please tell folks to go through their local leadership. They have been extremely responsive in responding to those complaints and working with families. And if they, for some reason things can't get resolved, it'll move its way up from me to Janae to the director. And we're certainly happy to step in at that point in time. But by all means, I know the leadership is in those local areas is absolutely willing to step up to the plate as well. So thank you guys for doing that too.
I have a question that I'd like to jump in on. I appreciate you guys having this meeting and giving us the information. It's really helpful when we hear different things that are happening just coming down the pipeline. I appreciate the ability to have us all together. I do have a question regarding the 1 hour response time on call-ins and investigations. I have heard that the 1 hour response time no longer exists or is being taken away, and I just want to know what that actually is looking like versus what I've heard and what the reality is with that. And then two, with the moving from the SBC to the motivational interviewing, if the goal is to roll that out with the contract on July 1st and the training is not until late summer or early fall, how can we ensure that we're going to be providing the parents with what they need when the contract is changing before the training? Thank you.
Erin, you're proving the point of a good town hall. This is our opportunity to level set legend and myth and rumor and all of those things. No, 1 hour response times have not gone away. That would be a real epic failure on our part to not have 1 hour response times. But we did do a lot of really deep work, and I'll turn it over to Janae and Lori to give some examples around what we were deeming to be 1 hour. That we didn't highlight this as key, but it did show up in the assessment as well. We had a phenomenally high threshold for 1 hour response times, and we were burning our people out to respond to things that frankly meant us waking up kids in the middle of the night and could have been a better process to interview while at school the following day. And so what we've done is revise that process, and we worked through a variety of different channels, including our wonderful team over in the AG's office, to think about what would be the right balance so that we are not leaving anything that is deemed an actual emergency off the table, right? But instead, again, focusing our folks in the right spaces to respond to those 1 hours. Janae, what else do you want to add in?
Yeah, no, that's wonderful. And I appreciate the questions, Erin. Something I'm going to flag quickly for those of you, our external stakeholders on this town hall. One of the opportunities we're going to have for you is to name what agenda items you want us to cover in future town halls. So like Erin, this would be a great one because I could have a few slides to show what the actual policy language shifts are. So I'll make a note of that. But those of you who have opinions on what we should be covering, just give us that feedback and we'll be sure to build that in. So to Director Garcia's point, no, 1 hours are not going away. But what I will tell you is Iowa has had some of the most aggressive response times compared to any child welfare system in the country, hands down. Nobody else has the 1 hour response time and the volume of calls assigned to them like Iowa does. So we went to review that policy, and what we saw in our own manual is we had, if there was an allegation that a parent was making methamphetamines in the home, even if that call came in at 2 a.m, our team had to go out within 1 hour. That would mean at 3 a.m, we're knocking on their door to go check out their home. And many of those allegations would not be true. And so we would be very disruptive to the family. And again, something that if law enforcement were contacted that somebody was manufacturing meth, they're not throwing on the sirens and going to knock down doors right then. So the place where you will not see any changes is if law enforcement calls and says, hey, we need CPS out here right now. Like, we're arresting parents. These kids are going to be unsupervised. When we get calls like that, we're going to still go out on site. But our policy, how it had been set up, is if a child was without a caregiver, that automatically got a 1 hour. That included times that law enforcement would be taking a kid, let's say, to shelter. You know, a case was brought to my attention where law enforcement transported a child to Children's Square, and then it was called in because the parents had had a domestic violence situation. The child was safe. We absolutely needed to go out. That kid was at shelter, and there was a significant issue with domestic violence. But that child wasn't actually without a caregiver. That child was at shelter where the child needed to be. We didn't need to go out at midnight to go check on that kid. In fact, the kid was asleep by the time we show up, and then we wake them up. So what we're doing is what we describe as kind of right sizing our responsiveness, not burning out our staff, being, of course, very responsive if law enforcement say, hey, we have a situation, we need you here right now. And whenever there is imminent danger, we're going to go out with those 1 hour times.
And what I'm sorry, Janae.
No, go ahead.
What I was going to say is what I want to tell the group here is that we did do a lot of refinement and to make sure we were seeing around all corners on this change. But if you have examples where you feel like that's wrong, please send that to us, right? I mean, that is something where, like, I feel there was an incredible amount of due diligence on this process change. And I absolutely support the rationale why, and I do not think it has compromised immediate safety. But in any revision of any practice, we want to make sure that we're not missing anything.
Yep. And we can cover that in greater detail again at the next town hall. Happy to do that. Your question, Erin, about how do we kind of reverse engineer out of SBC and into motivational interviewing when that training is not going to be fully deployed into the beginning of the next year. We will continue to have FCS staff who are already trained in SBC and are already credentialed in SBC. And so we are going to be amending the contract to say that they do not need to continue to train those staff because we are backing out of that model. And really what we're going to be shifting into is a family casework model, which I think is actually going to resonate a lot, both with our judges and our legal community, because it will probably sync up better with how you understood or some of the pieces that you appreciated of FSRP. The idea of looking at the safety and the permanency and the well-being in a holistic manner. So that those transition pieces, we're going to have to fully land that over the 6 months. But what you'll continue to see is the SBC approach until we fully integrate into the MI.
Great questions. Anyone else?
I don't want to be that person, but I definitely have questions that maybe other people also have, so I apologize. We talked about the group care, and I think we all agree that the last place we want kids to be is group care. We would obviously rather have them with family, fictive kin, foster, not group care. With that being said, though, we continue to have an issue or a lack of beds, especially for girls. And I know that's been an ongoing issue now for a while. And now we've lost those 12 beds at Bremwood. And for the kids I've had there, no love lost on that getting pulled. But what is the goal or plan when it comes to truly implementing more spaces? Because those are the kids that I then have sitting in shelter, like you said, Janae, for an extended period of time because we can't locate homes. So I just want to see, I guess, what the goal is for that.
Yeah, absolutely. So we've got a really significant initiative in the tail end of the legislative process. Shout out to our phenomenal partner, Christy Oliver here for some really deep work to get here too. So really, I mean, one of the things here, Erin, is that, and it says, Carrie just put the chat for those of you that can't see that she has the same question too. So look, you know, to be incredibly blunt, and I've just decided to take the filter off on this conversation because Janae and I have been talking about it. Well, I think at this point for years, right? I remember very early on conversations in my tenure when I first met Janae, long before she was in this role, around the way we're treating kids, like putting kids who can't be safe in a home into a space. It's supposed to be therapeutic. It's the T, right? QRTP. But y'all, it's not. It's not the level we need today. I think we try really hard, but group care is an outdated practice. And we know that kids need something different. And some kids need a really high level of care, right? They struggle. We need to understand who they are, what needs they have, so we can get meds right and we can get therapeutic interventions correctly. And so what are we doing there? Well, it cascades. We ourselves at HHS are a provider of the highest level of care. So last year we set out to specialize our facilities. That meant we changed our Independence MHI campus to be that level of care for youth. So child adolescent specialization, not just psychiatric care, but focusing on behaviors as well. So intensive supports around psychology there on that campus. And we reserve that space to take in youth without placement so that we can get a better understanding of who they are and what their needs are in our care. As Janae mentioned, we also launched the Foster Care Center of Excellence out at UIHC. And at the university, we have a level of multidisciplinary teams, including neurology, that often is the missing puzzle piece of why behaviors are off, and what, again, that right level of care is for youth. And our system has not had that at all, really, in the level that we need it. And then comes PMIC, right? So every PMIC in the state is on a wait list. You all know that. And we need additional capacity there, but beyond just more beds, because we have a capped number of beds in statute for Medicaid beds, we needed a different type of bed. We've been working with our providers in state and one provider out of state on what that would look like. And I am very hopeful that the legislature will take action with the governor's support this session on moving forward on that plan. So specialized capacity for PMICs is the space that we really want to put our effort. We're looking at, somewhere between, at the low end, 40 beds, on the higher end, more like 80 beds, just below 100 of additional specialized capacity that meets that higher level of care and works on really specialized needs. The idea would be that, and it comes with an enhanced rate, it would not be all providers. And that would really fill that gap, as you just mentioned, Erin, around the specialized needs, even for the young ladies who are out at Brentwood today. I mean, when I look at them, that's really the level of care that we're missing and that is needed. And then we intend to do more work around PMICs over the course of the next year to year and a half. It is a long overdue regulatory change in rewriting the rules around PMICs and really diversifying and specializing that capacity. Ultimately, that plan ends with dissolving group care as we see it today. We're not, so it's a 2 to 3 year plan, but we are well on our journey to getting to that space. And at the lower end, we've got step down filling out with the launch of therapeutic foster care. And we've got some other supports that will be more whole family interventions that are in development, and we can certainly talk about at a deeper level in future town halls. Janae and I are involved at a federal level with a number of small group invited working sessions with other states around how to solve these incredibly challenging problems. But I really do feel like those are the right investments right now. We don't want to overbuild. We want it to be right and right sized and highly specialized, intensely therapeutic, and with step down, because the goal in all of this interventional effort is to get back to family, a family-like setting.
I'm gonna jump in because I have to say it. Erin, success for us, and I know you, and I know these are your values as well. Kind of our litmus test is we know that our hardest kids that we're caring for, they probably need the most. And far too often they're getting the least. And we believe very strongly that success will look like the same consistent caregiver who wakes up those kids that we care about, who are right now in residential care, are the same caregiver who tells them good night. That is the only way, the same consistent set of eyes and relationship giving with these kids, that we will know when they are on psychotropics, if the psychotropics are causing adverse effects. The only way we're going to know if their anxiety is increasing and creating education performance challenges or things that look like school refusal, but are really being caused by other things. We can never get to that space with how group care currently operates. And we see it. And then the outcomes are terrible and the costs are high.
Right.
With Director Garcia's support, we know that we can do better, and it's going to take a lot of work. It's going to take therapeutic foster homes. It's going to take treatment foster care. It's going to take specialized PMICs. It's going to be a revamp to really build out things in a way that our kids do better. We want to get to the place that families and children are better off because we got involved. And far too often, those long-term stayers in residential care, they are way worse off than when we first got involved with them.
Mm-hmm. And the last piece of that would be those prevention efforts, right? Which for us on the broader aspect of the system, not even in the child welfare lens, would be, no family has to resort to child welfare to get services for their child. That's a failure of the system, and a really expensive and always incredibly costly, and I don't just mean financially, way to address behavioral health or developmental disability challenges. So on the ID side, right, it looks like building out Woodward Center of Excellence. We're specializing that facility to really focus on respite and crisis stabilization and outpatient services. We're also going to be launching outpatient services at the Independence MHI campus as well. It looks like waiver redesign and making sure that supports are there for families and for individuals as they age into adulthood to be supported in living in the community of their choice in a real and meaningful way. And so there's extensive work on that side, and all of it together gets us to a space, Erin. It's not just if there was one answer, a state would have done it and we would know the answer to this, right? It's got to be a really fulsome change. And when we talk with our colleagues at a national level, of which Janae and I had a chance to do last week, what I see is that, we've really this is incredibly intense work to redesign these spaces. It's highly technical. It's a lot of skill on the financial side, beyond just the service array piece. The good news here is that I do believe we've got the right people sitting in the right seats to do that work. We're supplementing with some really smart people on the contractual side for some of those cost calculations. And I am lucky to have the force of all the programs under my jurisdiction to move those levers and to provide recommendations to the legislature that really do leverage Medicaid in the right way. And not all of our colleagues, or in this case, not all of Janae's colleagues, can say that. So we're on to something here, and we're learning from other states. And it's been a really incredible learning in this build on the behavioral health side, on the Medicaid side, and the child welfare and disability space. Anybody else? I want to acknowledge that we're a few minutes over. Really am happy to stay, but if everyone's being shy on questions and we're just going to talk to Erin, we can talk to Erin.
I was gonna say, I always have questions, you guys.
It's fine. It's really fine. And listen, For those of you that are just in listening mode, totally fine. The first town hall, you're like I get it. I'm you at a party. I'm in the corner. I'm like surveying the space. Janae's in the middle and talking to everyone. I would be doing the same thing you are, right? But what I need you to know is that, well, our behavioral health bill just passed, y'all. Amazing. Amazing. So what I want you to know is that we want to hear your feedback, your questions, your concerns. We need that. I do this work in a number of other spaces, and Liz Matney does it on the Medicaid side. No question is too controversial. We need to hear from you, right? And so just know that if tonight is not that space, let us know. You know how to reach out to us. And we very much appreciate your attention and your ongoing partnership as we work to strengthen the system. So thank you.